my healthcare brothers and sisters. I hope that you are having a wonderful day. We've talked about isotonic, we've talked about hypotonic. Now it's time to talk about hypertonic solutions. So in order to understand fluid movement, we really have to understand a solution's tonicity. So tonicity is measured as the effective osmotic pressure gradient, that is the water potential of two solutions separated by a semi-permeable cell membrane. So concentrations of solutes are dissolved in a solution, which determines the direction and extent of diffusion. So fluid tonicity is the comparison of IV fluids to our blood plasma. So if we have an IV fluid that is less concentrated than our blood plasma, then we have a hypotonic solution less than 250. If we have an IV fluid that has a similar concentration to blood plasma, then we have an isotonic solution. That's usually between 250 and 295. And lastly, if the IV fluid is more concentrated than our blood plasma, then we have a hypertonic solution that is greater than 295. So what are hypertonic solutions? It's when a solution contains a higher concentration of solutes than another less concentrated solution. Is also known as hypertonic. So the concentration has a higher osmolality to blood. So osmotic pressure outside of the cell is higher than the osmotic pressure inside of the cell. The water inside of the cell moves out in an attempt to equalize that osmotic pressure, causing the cells to shrink and shrivel. So again, normal osmolality of blood is between 270 and 295. So these are going to be much higher than 295. And a quick NCLEX tip to help you with your exams is that cells shrink when they are in a hypertonic solution, just like active people. So if you've got a really hyperactive person, that's going to lead to shrinking body mass, right? Same thing with our hypertonic solutions. We've got really active hypertonic solutions causing our cells to shrivel and shrink. So what are some examples of hypertonic solutions? Well, we have 1.5%, 3%, or 5% sodium chloride. So really it's any solution that is greater than 0.9%, which is our normal sodium chloride, is considered hypertonic. So our 3%, for example, sodium chloride has an osmolality of 1030. That's insane, right? When blood is normally 270 to 295. Even worse, our 5% sodium chloride has an osmolality of 1710. So these are very high osmolality, very concentrated. Our D5 normal saline or D5 lactated ringers has an osmolality between 527 to 560. Our D10W and D50W has, and again, it's any solution that is greater than our 5% dextrose in water that we talked about before. Remember, our D5W is isotonic in the bag and it's hypotonic once it reaches inside the body. Our D10W osmolality is 505 and our D50W osmolality is 2525, so very high. And lastly, our D5.5 normal saline is 406 when it's in the bag. So here we have another situation. So it's used a lot with our diabetic ketoacidosis patients. Once that blood sugar has been brought down, usually in the 250 range, we'll shove on this D5.5 normal saline because it really helps maintain blood sugars as well as maintain fluid that's in our vessels. So let's talk about fluid shifts. So again, the osmolality for our hypertonic solutions are going to be greater than 295. So what does that mean? Well, fluid is going to shift into the blood plasma and out of the cells and tissues. Osmosis again, water moves from the lesser concentrations to the higher concentrations to our dilute solids. We don't want our solids to be too heavily concentrated on one side and not on the other, so it shifts in order to dilute those solutes. So what happens when that shift occurs? Well, of course, our cells are going to shrink and shrivel because all of that fluid is coming out of the cell into that extravascular space. So let's talk about some reasons why we would give hypertonic solutions. One of the indications would be with hyponatremic patients. So if we've got dangerously low sodium levels, usually less than 120, say we've got someone with a sodium level of 110, normal being 135, to 145, that could be a major problem, right? So if we've got these chronically low hypernatremic patients, then we start to see increased risk for seizures. We need to have that salt. It helps us maintain our neurological functions. It's one of those positive and negative cations that we talked about before. Cerebral edema would be another reason why we would give these high sodium chlorides that we talked about earlier with our hypertonic solutions, because as we know, fluid follows salt, right? So if we've got all of this edema taking place in our brain, this fluid actually helps pull off, because remember, it helps those cells shrink and shrivel. So it's going to help start to pull off all of that excess fluid that we don't need, causing all of that edema. Peritonitis and also peritoneal dialysis would be another reason why we would give hypertonic solutions. As for contraindications, we want to make sure that we're correcting sodium slowly, very slowly. Why? Because again, water follows salt. If we're correcting it too fast, we can actually cause neurological damage as well as increasing the risk for seizures even higher. And we also have that risk for cellular dehydration. So as before, when we talked about our hypotonic solutions, we've got all these fluids that are shifting into the cells. So it really helps when we have cellular dehydration to help revitalize those cells. But if we're giving a lot of hypertonic solutions, we're going to be pulling off all of that fluid that's inside our cells, right? Because it causes them to shrink and shrivel, thus leading them for an increased risk of developing cellular dehydration, and we don't want that. Greater than or equal to 3% normal saline is for central lines only, because it is very caustic on the veins when you give such high sodium chloride levels, specifically hypertonic solutions, to patients. So you really want to make sure that you've got a central line when you're giving those high normal salines. And also heart failure, renal failure, we have a higher risk of fluid overload. If the heart is not working appropriately and the kidneys aren't working appropriately, we're unable to excrete all of this excess fluid, you're going to have the risk of having some kind of fluid overload. If you want to review fluid overload a little bit further, I highly suggest that you recommend my video where I talk about fluid excess, and I'm going to leave a link up here in the corner. And lastly, the goal of hypertonic solutions is we want to shift fluid outside of the cell and tissues into that intravascular space, kind of like what we talked about earlier with cerebral edema. So again, nursing considerations when it comes to hypertonic solutions is really we want to monitor for that fluid overload. Because if we're giving too much, we're giving this excessive fluid, it's going to absolutely cause fluid overload, especially when we're pulling all of that fluid out of our cells. So you're going to see those bounding pulses, the high blood pressure. You're also going to have that jugular vein distension, JVD. You can hear crackles in the lungs, especially as fluid is starting to build up in those lungs. Edema, cerebral edema everywhere. It's just massive edema. And then you also have a decreased SpO2 because of the fluid buildup, limiting the oxygen diffusion in the lungs. I hope that this video was helpful for you in passing your nursing exams like a boss. If you have any questions, please feel free to leave them down below. I love answering your questions. Make sure that you follow me on my social media. I'm on Facebook, Instagram, and Twitter, as well as here on YouTube. Make sure that you subscribe as well as like this video. I also have a website at www.nursecheung.com where I will have NCLEX style questions as well as additional resources with each of my videos. So make sure that you check that out. But until next time, I hope that you're having a wonderful day, and I will speak with you all again soon. Bye!